All right, well, I think we should dive right in. My name is Drew Ludlow, and I'm the president of the Rare Kidney Disease Foundation, a patient-driven group to support the incredible researchers and scientists, and of course, patients all around the world. And we've seen just such incredible work these last few years since we started, and just feel so privileged to be associated with such a high caliber group. We're kind of helping to convene this second annual ADTKD International Summit, which we're thrilled to have so much participation in, and we have two very full days, today scientific and tomorrow more patient driven. And so we want to dive right in. And so without further ado, I want to throw over to Greka, who of course heads the Greka lab at the Broad Institute, and is such a massive part of the progress we're making here. And we're just thrilled to have Anna kind of head up today's scientific program. Anna.
Hello, everyone. No matter where you are and what time it is in your time zone, it's really a tremendous pleasure to welcome you to the second annual International Summit for ADTKD. It's wonderful to convene our community for the second time virtually, but still able to come together to exchange ideas, to hear from everyone's perspective. We have physicians, scientists, patients, colleagues from all over the world who are very interested in being a part of this community, hoping to make progress toward treatments. I think that's the common mission that we all share, to try to create treatments for patients everywhere. And so to this end, I think this year is a particular milestone that I just wanted to mark briefly. And we'll be hearing from all the important members of this community who are spearheading the efforts to get a treatment to the clinic over the next couple of days. So I just wanted to say for myself that it's a tremendous honor and privilege for me and my team to be a part of this effort. It started with my arrival at the Broad Institute in late 2015, 16. That's when we first started out understanding one of the genes that causes ADTKD. And I think it's remarkable. And I would challenge those of you who are drug developers in the audience to suggest a faster timeline. I think we couldn't have gone faster than we have. We worked over the course of 3 years from 2016 to 19, all together as a group, an international group working across borders to understand the mechanism of these diseases and also to develop a therapeutic lead. That was accomplished by 2019, which was an incredibly fast timeline. And then from 2019 to today, the fall of 2021, and despite the pandemic, we are actually in this incredible position to have been able to pass off our discoveries and the work that we have done in the lab to develop drug-like molecules to a startup company that will now truthfully be able to take this discovery all the way to the clinic. And you will be hearing about this tomorrow from Peter Mundell, who is now spearheading that effort. So it is incredible in the span of 5 to 6 years to go from understanding the gene to understanding the mechanism of a disease, to developing a therapeutic lead, and then to ultimately developing drug-like molecules that can actually go into patients in the clinic. It's an incredibly fast trajectory. We are very blessed to be able to have arrived at this junction. And of course, the future is bright, and I couldn't be more hopeful about patients with ADTKD and treatments coming down the pike over the next just a few short years. And so I'm very, very excited that we have made it this far. And of course, we have a lot of work to do, but as a community, I think that we can make this happen. So without further ado, I just really wanted to run through the agenda for the next couple of days. It's pretty busy. But I think we have incredible speakers lined up. Again, all of them are my valued colleagues, friends in this effort. And so we start with my most trusted partner, Tony Bleyer at Wake Forest, who of course all of you know. He's an incredible clinician and an incredible partner to our project. And he will be speaking about SGLT2 inhibitors and ADTKD this morning. After a short break, we will have our keynote lecture, which is spearheaded by two remarkable colleagues, Julie Roignot from our team at the Broad, and Greg Papagregoriou from the University of Cyprus, who have worked hand in hand on a very important aspect of how you take a treatment to the clinic, which is developing biomarkers. Then we will transition to Masha Alimova, also from our team at the Broad, who is an incredible drug discoverer in building high content imaging assays to facilitate these discoveries. She has been instrumental in our efforts, and she will explain to you how we got there. So we will hear from Masha. And then last but not least, we're actually going to hear from a very valued colleague over on the other side of the pond, Eric Olinger, who will speak about ADTKD from the perspective of protocol biopsies and how those may be deployed in future clinical trials so that we can make progress toward the clinic. We would like to reserve a Q&A for all speakers at the end of this. So please put your questions in the Q&A and we will moderate this and have a discussion with all the speakers. And then the treat of the day is Katie Reed, who is an incredible member of the Rare Kidney Disease Foundation. We'll give you a preview of tomorrow's events, which include welcoming remarks from Tony Bleyer, and some additional discussion from him about COVID and ADTKD, which I'm sure we're all interested in hearing about. But importantly, we will also have a keynote from Peter Mundell, who is really spearheading the effort to take the discoveries from the lab to real-world clinical trials. And as an extra special treat, we also have a valuable and important partner in our efforts to bring treatments to the clinic, the FDA, represented by Elisa Thompson, who will tell us about how the FDA works with patients and physicians and scientists to advance new therapies toward the clinic. And the most important part of the whole event, of course, is the patient voices. We will conclude with that, and this will be a session led really by our friends in the Rare Kidney Disease Foundation, Drew and Katie and Richard Nelson, Katie Reed and Richard Nelson, who are going to lead the conversation about how you can continue to organize as a community, which is going to be very important, both for clinical trials as well as for advocacy in trying to bring these treatments to the clinic. So without further ado, I would like to pass the baton over to my very trusted partner, Tony Bleyer. Tony.
Thank you very much. Can you guys hear me okay? Okay, and I'm sharing the screen. Let's see. Oops. Hold on. There you go. Can you guys see the slides? Okay, very good. All right, so thank you very much. It's just so great to be working with Anna and also with our patient foundation that organized this. They've done a great job this year, all of these groups working together. And it's just really great for us here at Wake Forest to be part. And a great part has been meeting patients and families with this disorder, as well as working with many colleagues from all over, which we've really, really enjoyed. And so this is our, as someone said, what's your true north? This is our true north at Wake Forest. So we're the Rare Inherited Kidney Disease Research Team, and our mission statement is helping one patient, one family at a time. I'm just going to go over a little bit our progress, SGLT2 inhibitors, a little bit scientific on COVID-19, and a little bit about FAN1 mutations. Kendra told me this yesterday. Today is the 6-year birthday for doing the testing for MUC1, the CLIA-approved test. And so we've done, working with the Broad, who does the testing, we've had 1,588 samples from 1,515 individuals and 379 individuals with a +C MUC1 insertion, 7 individuals with a +A, and a 25% positive test rate, which has been really great. And we couldn't do it without all of these people. And especially I'd like to thank Megan Harden here in the corner, who's just been so helpful. Let's see if I can make this smaller there. Megan Harden has been incredibly helpful in getting us the samples. And of course, members of my lab team, which include Vicki Robbins, who's been our research nurse, Lauren, and of course, Kendra has spearheaded everything. Alice has collected the samples and processed them, and Abby. And then of course, our team at the Broad led by Anna, and here's Dr. Lander, and our friends in Prague who help us with other difficult cases. So it's really been great, and we're really happy about that. From our Wake Forest standpoint, we continue to get referrals. We've had a total of 855 total families referred. 190 families came directly from patients without the help of their doctors, 404 from academic practices, 252 families from private practice, and we now have 207 families and 526 patients with UMOD, 118 families and 358 patients with MUC1, 17 families with renin, and we've gotten a lot of this genotyping done by the Stan Kamak lab in Prague. And the good news is we were on hold with the MUC1 testing due to a lack of one of the reagents. We now have that reagent, and so we're doing much better with that, and we're excited about that. Right now we're in the midst of an observational study, and what the observational study does is we're following patients prospectively with EGFR measurements every 4 months. And we're trying to do it mostly electronically so that patients just get an email reminder and go to the lab automatically. They do a limited survey every 4 months, and we'd like to get other groups internationally to work with us on this project. And we know doctors like Michael Wiesener in Germany are interested in using our REDCap database to enter their patients in, and this is going to be staying just with their group, but it'll be in a way that we'll be able to share data in the future. Our observational study includes UMOD and MUC1 patients who are not on dialysis or transplanted. Just wanted to highlight, we have 50 patients in the study with MUC1, 54 with UMOD. Our goal for this year was 100 patients. We're interested in the diet. Only 2% are vegetarians or on a vegan diet in the MUC1 group, 6% in the UMOD group. 1/3 to 1/2 have high blood pressure. And we're trying to get more patients in the EGFR greater than 60 group. But we're excited about our current patient populations that we have. And here we are, we had 104 enrolled, 86 have completed the initial survey, 59 are in for their first quarterly visit. So now I'd like to talk about SGLT2 inhibitors. And I'm going to give you a little background, talk briefly about urinary KIM1, talk about hemoglobin as a marker in SGLT2 inhibition, methods and results. So we all know that SGLT2 inhibitors work here in the proximal tubule, and they decrease oxygen consumption in the proximal tubule. As nephrologists, we know that a proximal tubule requires a lot of energy. And one thought is that this increased energy requirement in the proximal tubule can be detrimental as kidney failure progresses. And if we could decrease this oxygen demand and this work, that this would help to slow progression of kidney disease. So we know that the glucose uptake inhibitors work here to block the SGLT2 channel, and they allow more glucose and sodium to go into the urine. The DAPA-CKD trial randomized 4,304 patients with chronic kidney disease to dapagliflozin or placebo. And it's important to note they went down to an EGFR of 25 to start the study. And the patients continued on the drug until they had an event such as doubling of creatinine or were on dialysis. So many of the patients were on the study even with a lower EGFR. A lot of people wonder, can patients be on this drug if they have a GFR of 20? And we know from this study that patients were not started at 20, but they were on it when they had a GFR of 20. The urine protein in this study could be very low, down to 200 milligrams per gram creatinine. Patients were receiving dapagliflozin 10 milligrams daily or placebo. And the primary outcome was a composite of a sustained decline in the eGFR of at least 50% or these other outcomes. The trial, as we all know, was stopped early due to efficacy. 9.2% of the dapagliflozin group had a kidney event versus 15% in the placebo group. And there were also less deaths in the dapagliflozin group. So the drug looked good for slowing progression of kidney disease, but also decreased cardiovascular death and overall death rate. Here's a slide that's been very important to me from this study. And when we look at this slide, we can see that patients sustain this immediate drop in eGFR. And if you look, there's a drop at 1 week, but that drop continues to about 1 month. And then there's actually a rise in eGFR for the next several months. So if you get a GFR at 1 month and it goes down, you will see it rise until the 3rd month. And then it will start, it will get back on its curve. Here's a placebo group, and you can see the groups intersected at about 12 months. We can see the benefits of this trial occurred regardless of urinary protein and occurred even at lower eGFR values. There was also a study looking at patients who were stage 4 CKD in the trial, and it showed that these patients also had an improvement in kidney function, or preservation of kidney function decline, I should say. So one thing is we don't have enough data that we're going to be able to look at long-term progression in our patients and compare it with placebo. So I was interested in looking at urinary markers. So one marker we considered was urinary kidney injury molecule 1. This is a marker of AKI. It has not been shown to correlate with CKD progression in diabetes or ADTKD. In diabetic patients, urinary KIM1 has been shown to decrease with SGLT2 inhibitor usage. And here we can see a study by Van Rooten in which they had 66 obese patients followed for 16 weeks. And this is what happened to the placebo group. They had an increase in urinary KIM1, while there was quite a significant decline in urinary KIM1 in patients on the SGLT2 inhibitor. Another thing that was found to be predictive, quite predictive, was hematocrit. And Christo Vonner, as we know, was one of the leading investigators in these trials. And he submitted an EDTA abstract, which showed a rise in hematocrit is a good predictor that SGLT2 inhibitors are helping the kidney. And what he found was that the hemoglobin, a rise in hemoglobin, mediated the effect of dapagliflozin on composite kidney outcomes based on multivariable analysis. And he found if you looked at the time-dependent change in hematocrit, if the hematocrit was rising, this mediated 99.5% of the benefit. So this is, of course, mediated it statistically. So if the hematocrit went up, it was an indicator of usefulness of these agents. When they looked at the 12-week hemoglobin or hematocrit, they found that this correlated and was responsible or mediated 80% of the benefit of these agents. So volume hematopoiesis markers were strong mediators of the dapagliflozin treatment benefit on the composite kidney outcome in EMPA-REG outcome patients. When considering changes over the full observation period, hematocrit mediated almost all of the dapagliflozin treatment effect. In a landmark approach, the week 12 change from baseline in hematocrit was the most substantial mediator, and in combination with A1C, systolic blood pressure, and FFA, mediated the majority of treatment benefit. So the reason I'm presenting this is because these are two things that we could look at in our database. So what about SGLT2 inhibitors and ADTKD? Currently, we have no other options for treatment for our patients. And I see many patients with advanced CKD, CKD stage 3 and stage 4, who are not going to be able to make it, I think, until the trial with the Broad compound in several years. And so they need something now. And we know that SGLT2 inhibitors appear effective in advanced CKD as well as chronic kidney disease. And we know now that they're indicated as a treatment for chronic kidney disease. These agents have an excellent side effect profile, and they may be particularly useful in UMOD kidney disease. So in UMOD kidney disease, we have uromodulin causes a leak of sodium at the thick ascending limb, and this is mediated by an increased reabsorption of sodium proximally. This also is associated with an increase in uric acid reabsorption, leading to hyperuricemia in these patients. So we know that these patients have a higher rate of reabsorption and in the proximal tubule, and so we thought that SGLT2 inhibitors, as they work in this area, may be beneficial in this condition. We also know, like any other kidney disease, hyperfiltration develops later in the course of kidney disease, and this would happen in patients with MUC1 kidney disease as well. So we decided that we would follow patients who are placed on SGLT2 inhibitors at the discretion of their nephrologist. Biomarkers are measured at baseline, 1 month, and 4 months. And then we get laboratory measurements of serum creatinine at least every 4 months as part of the study, though they could get them more frequently at the discretion of their doctor. We know that we're not going to be able to show efficacy of this treatment because there were thousands of patients in the DAPA CKD study, for example. And we're not going to be able to see that. What I'm hoping is that we'll be able to show that the treatment is not deleterious. And if we could show that the treatment really has no disadvantages and may be potentially beneficial, I think there's going to be a lot more data coming out over the next several years looking at SGLT2 inhibitors and helping us to better decide. These markers like hemoglobin, studies in patients with tubulointerstitial kidney disease, all of these things will help us in deciding whether our patients may benefit from these agents. And I'm hoping that someday, patients who are 20, 25 years of age may be able to start on these agents and that they may slow progression over the long term. So far, we have 16 patients who've been started on SGLT2 inhibitors. I'm sorry about this slide. It's actually 8 and 8 of UMOD and MUC1. And you can see the mean GFR is quite low in the patients, was 39. 14 were on empagliflozin and 2 were on dapagliflozin, all just on the starting dose. I showed you this slide before, which showed the change in GFR over time. And so we can see there's a decline initially, loss of 4 ml per minute per year, and then there's a bump up, and then there's a continued decline. And Dominic Stoibel, who's worked with us in our rare inherited kidney disease study and now works with these agents, told me, he said that we really should start looking at 3-month values and to look at the change in GFR from 3 months on. If we look at the change in GFR, in the patients, if we look at the change in GFR from baseline, it will look like it's going down too much. And if we look at it starting at 1 month, we won't take into account this rise. So we're looking at change in GFR from 3 months onwards. Here are our patients that were in the study. Here are the number of patients we had, and here's a change in GFR. So in this study, we can see at 12 months, the patients had an average loss of GFR in the placebo group of about 4 ml per minute per year. We know that our patients with ADTKD have a loss of about 3 ml per minute per year in general. So we started the drug, and as you can see, by month 2, there was a GFR drop of 5 ml per minute per year. And there are a number of studies now that show it doesn't really matter how much the drop is at several months. That's not an indicator of future performance. Then we saw the rise, like had been described. And things seemed to be very steady until 10 months when we saw this decline. But this is only data in 2 patients that we have. And as I'll show you the data on these 2 patients. One patient now we have who's been on drug for 13 months, and he's had a loss of 4 ml per minute per year. And another patient who's had a loss of 8 ml per minute per year, but she was started on a diuretics during this time, and I'll show you her data in a minute. If we look at the change, so here's a change in slope in GFR. So this patient I talked about, we're giving ourselves the worst case scenario starting at 3 months and looking at slope. So previously he was losing GFR. So he's our longest patient in the survey, 27 GFR 34. So really advanced kidney disease. Really want to see what we could do to help him. Before his slope prior to SGLT2 inhibition was minus 4.2. From 3 months out, it's been minus 4.9. He had an increase in his hemoglobin, but we can see here the rise in urinary KIM-1 at 1 month. So almost all the individuals demonstrated a significant rise in urinary KIM-1 at 1 month. And the change was actually from 2,300 to 5,000, which was significant, and was not significant, that was P equals 0.08. From this graph or this figure, you can see that we've had 8 patients who've been on medication for at least 3 months. And a number of patients dropped out of the study because they did not like seeing the GFR decline after the first several months. So if we look at the change in GFR, the slope prior and the slope at 3 months, it was minus 2.2 ml per minute per year on average in this group before they received SGLT2 inhibition. And then it was minus 1.8 after receiving it. And this is only for patients who've been on the drug at least 4 months. And then we look at or 7 months, because it was 4 months after the 3 months. And then if we look at hemoglobin baseline, we can see that it went up significantly from 11.9 to 12.3. So that was good news. As you look at these graphs, you can see the complexity and how we'll never be able to tell if a change in GFR, if there's a benefit. So here's our patient who is about 30 years old, and you can see he's had a decline in kidney function over time. Of course, it's not totally linear, and we can see right before he went on drug, over the last 2 years, he was having a significant decline. So where do we look at the slope? Should we look at the slope from here, from here, from here, prior? We decided to just go all the way back with the slope to how many readings we have. And so his slope here was minus 0.0117, and here he had about a similar change in GFR, change in slope over time. But it looks like he's stayed fairly stable, right, compared to this or this timeline. So we've been happy at the slow rate of decline, but as you can see, with each data point, the slope changes a little. And dietary changes like eating a high protein meal before getting tested could really affect the GFR and the slope. Here's another patient, and this lady had quite stable kidney function before she went on medication. She had the initial drop in GFR, and where do we go with her? You can see all these data points, and depending which data point we pick as her baseline will determine her slope very much. So we just went with a 3-month slope like all the other patients, but as you can see, there's just such variation in her GFR that it's really difficult to say what's happening. But I think overall her GFR has been stable. Here was the concerning data about the urinary KIM-1, and you can see it just about went up in everybody. Now, it's important to realize this was measured right here. So here was where the urinary KIM at baseline in 1 month. So the two readings were very close, and we have follow-up data now out to 12 months. And the changes in urinary KIM-1 did not seem to prophesy that we were going to see really deleterious changes in GFR. So we decided to go back and look at urinary KIM-1 to see how it correlates with outcome in our patients. So this is just a group of our patients with UMOD and MUC1. And you can tell from the R-squared values that there's really no correlation between eGFR slope and KIM-1 measurements. So here are several patients with extraordinarily high urinary KIM-1, and these are adjusted for creatinine. And you can see they have a 0 change in GFR over time. And here are patients with very low urinary KIM-1s, and they have a very high, these patients have a high loss of GFR. So the urinary KIM-1 does not correlate, but of course I was concerned. I was hoping to see that it would match with the SGLT2 data for diabetic patients. SGLT2 inhibitors were well tolerated. There was no occurrence of urinary tract infections, fungal infections, or non-ketotic DKA. Patients basically could not tell they were on the agents. But the one thing that is important to realize is they're probably a little dehydrated or volume depleted at times. And so it's important when they get their labs that they're volume replete. 5 patients stopped SGLT2 inhibitors. And most of these patients who stopped it, basically all of them who stopped it, stopped because they had an anticipated eGFR decline. So these patients are very concerned about their GFR. That may have prompted a lot of them to go on SGLT2 inhibition. And even though we told them they were going to have this drop in GFR, a lot of them just said, you know, we're not going to tolerate, we can't stay on the drug. And one patient actually stopped from anxiety because he saw his GFR go down, and he was just so anxious about it that he decided to stop drug. So in conclusion, the SGLT2 inhibitors were very well tolerated by the patients. Kidney function follow-up at 1 year without significant declines in eGFR. Urinary KIM-1 increased, which we think was not good. Hemoglobin, I shouldn't say not good, but it was something that we had not hoped for. Hemoglobin hematocrit increased, which was good. We are now in this cohort measuring urinary KIM-1 and NGAL at baseline 1 month and 4 months follow-up. We are also measuring urinary DKK3 at baseline 1 month and 4 months using safe-back specimens. And we continue to follow the present cohort. And if you have patients as well who are on these agents, we'd love to know and add them to our data. Just a few quick updates on COVID-19. Patients with CKD are at increased risk of COVID-19. So we have 2 groups of patients. Of course, UMOD is expressed solely in the thick ascending limb, nowhere else in the body. MUC1 is expressed on many epithelial surfaces, including the lungs and in the nasal mucosa. So we sent out a survey to the patients in our registry regarding COVID-19 affecting them and family members, and our primary outcome was death from COVID-19. And first, so these are the MUC1 patients, we got data from family members. We got data from the survey responders about their family members who had died. And I think the biggest thing, we had 43 with MUC1, 31 with UMOD, 5 with renin, and altogether 79 ADTKD patients who had COVID. So these are the patients who had COVID. And 8 patients died of COVID-19. And of these 8 deaths, or 9, hold on. These are the patients who died who had MUC1. So 8 patients in the MUC1 group, 19% died of COVID, versus only 1 or 3.2% of patients in the UMOD group. So there was a significant difference in the outcomes in patients with MUC1, with 8 deaths in the MUC1 patients and only 1 death in the UMOD patients. We didn't have enough data to do multilinear regression, but when we look at the data, we can see between the two groups, there were more men in the MUC1 group. The mean ages of the patients was about the same. The mean age of the patients who died of COVID with MUC1 was a little bit higher as expected, but they weren't extraordinarily older. Only 25% of these patients were greater than 60. The BMI was approximately the same, a little bit higher. No current smokers, 50% had been vaccinated, and 89% of the patients who died of COVID and MUC1 had been transplanted. So we think that COVID-19 may be worse in patients. Obviously, this is a small amount of data, but we think that patients with MUC1 kidney disease may have worse outcomes. We did have one patient who was 50 years old before vaccines were available. He was a runner, ran 2 miles a day. His GFR was about 60. He died of MUC1, he died of COVID, and several transplant patients, as we talked about, passed away from COVID. We have data from Dr. Stavro in Cyprus on his MKD cohort, and 2 out of 23 patients, or 9% of their patients, died from COVID. Who had COVID, I should say. We're going to be sending out a brief COVID questionnaire to all of you to see if you have any MUC1 or UMOD patients that you know of who died of COVID. And just finally, I'd like to say a little bit about biallelic FAN1 mutations. It's not really ADTKD, but I think a lot of us are just interested in rare kidney diseases. FAN1 mutations cause a condition called karyomegallic nephritis. So these patients are found to have very large nuclei, and these are due to enlargement of the DNA and issues with folding and DNA repair due to the FAN1 mutations. Patients have a bland urinary sediment, and what's been well reported in this cohort is that these patients get chronic kidney disease. A group led by Peter Conlin and Dr. Murray and Dr. Connaughton, among other authors, looked at their patients with FAN1 mutations and showed that, especially after transplantation, they had elevated cancer risk, they had elevated risk of pulmonary disease, and high rates of death after transplantation. The problem is there are only like case reports of 3 or 4 families, and most of them concentrate on the kidney disease. So we're going to be sending out a survey. If you have any patients with biallelic FAN1 mutations, we'd love to have you join us as a co-author and fill out data about your families. And I think it'll really help these families to decide what to do, because I have several patients with this, and we now don't know what to do about transplantation, screening for cancer, or pulmonary disease. And I visit our dialysis unit in North Carolina in Mount Airy, and I drive by Pilot Mountain every 2 weeks, which gives me a little bit of peace. And so here are many, I shouldn't say all, but many of our collaborators who are just so close to us and have been so great to work with. You know, for a rare disease to have so many people interested in. And the other thing I'd like to say is that these are not just scientists who are interested in the science, but really interested in seeing the patients. And Dr. Lander even himself would come in on Saturdays to meet with patients when we were at the Broad. And just everybody here is just so interested in helping patients. Thank the Rare Inherited Kidney Disease Foundation, which put this together, which has been awesome. Our Facebook page creator, Michael Schaefer, has been great. If you have patients, I would recommend that they join the foundation, they join the Facebook page, and just thank you to everybody who's worked with us. And I think that's the end. Okay, so I'll stop sharing now.
Thank you so much, Dr. Bleyer. That was incredible as always. And I mean, nothing like hearing from the one who's been working on this for decades and decades. So really appreciate that. We're going to take a very short break. We want to stay on schedule. So we're just going to take about a 4-minute break here and come back at a quarter to the hour. So please stay tuned. But we just wanted to give people a chance to take a bio break or whatever if needed, and come back for our next talk, which is of course our keynote. So please stay tuned and come back in just a few minutes. All right, we'll come on back here, and again, Anna already did a fantastic introduction, so there's no need to reintroduce, but want to send it over to Julie and Greg for our keynote. Take it away, please.
Hi, everyone. Thanks for the opportunity to present our work today. I'm going to share my screen now. Up. Can you see the full slide? Yeah.
Yep.
Okay, great. Okay, so today Greg and I are going to talk to you about biomarkers for ADTKD MAC1. But first, I would like to start with a little bit of history on the project. So in 2010, the Carlos Slim Foundation and the Broad Institute joined forces to launch the Carlos Slim Center for Health Research. And Broad Institute scientists set out to find the mutation causing a rare kidney disease that at the time was labeled as medullary cystic kidney disease 1. So in 2013, the mutation was identified in the genomic blind spot thanks to recent advances in DNA sequencing technologies. And this disease that is now renamed ADTKD MUC1 is caused by a frame shift mutation in the MUC1 protein, which is a protein normally present at the surface of multiple epithelial cell types, where it forms the mucus and also protects against infections. So this mutation happens in this VNTR domain made of a repeated 20 amino acid sequence, which length varies between individuals. And the mutation creates a frame shift. And if you're not familiar with what a frame shift is, I have illustrated this here. And so this frame shift causes the generation of a completely different protein after the mutation. And this protein cannot be processed by the cells normally anymore. And it starts accumulating and causes a progressive loss of kidney function. So finding the mutation led to a massive collaborative effort from multiple Broad Institute platforms and teams to generate cellular and animal models of the disease so that we could develop our understanding of the disease mechanisms. Then the Broad Institute launched a drug discovery pipeline to identify a compound with the ability to improve the outcome of the disease. And because this would not be possible without the help of clinicians and patients at that time, like I said, Eric Lander, the president and founding director of the Broad Institute, also reached out to leaders of the ADTKD MUC1 community. And I want to name Tony Bleyer, who just gave this really good talk, and the Cyprus Biobank, represented by Greg here today. So in 2019, we published the identification of a drug candidate, BRD 4780, capable of clearing the toxic accumulation of the mutant MUC1 protein. And what was also amazing about this drug is that it is also showing potential towards other proteinopathies. So here I wanted to illustrate the activity of this compound, BRD 4780. On the top here, you can see images from healthy study models, cells, mouse kidney, and patient-derived kidney organoids. In those middle images, we are looking at the corresponding disease models in which you can see the accumulation of the mutant protein in green. And on the bottom images, you can see that when we treat those models with this compound, we see a nearly complete removal of the toxic protein. So in 2019, we also launched the very first biomarker trial and clinical study for ADTKD MUC1, which lays down a path for future clinical studies. And this work, like Anna said, attracted the interest of venture capitals who decided to invest in that project. And so this year, a biotech startup was created to take this project from the academic world to the pharmaceutical industry. And we have very lucky to have Peter Mandel present today, who is one of the founders of the startup. And Peter is going to tell you all about that tomorrow. So for those who are not familiar with the term, I want to define what biomarker is. The biomarker is a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacologic response to therapeutic intervention. So to give you a few examples, these measurable characteristics can be a time to kidney failure or hospitalization or dialysis. It can be the glomerular filtration rate, which directly correlate with a kidney function, or it can be a molecular marker, like a marker of kidney injury, such as KIM1 that Tony just talked about. So at the very beginning of a drug discovery pipeline, you always need to start thinking about your biomarker strategy. This is absolutely essential to support sound clinical studies and answer questions such as, is my drug working? What is the appropriate dose or schedule of treatment? And within that disease, which patients should be included in the clinical study to maximize the potential outcome? But the biomarker strategy for ADTKD MUC1 presents many challenges that are not necessarily specific to this disease, but are actually often shared by a number of rare and slow progressive diseases. So one such challenge is the lack of adequate biomarkers for assessing treatment effects. The endpoints currently accepted by the FDA for kidney disease are kidney failure and death, or surrogate endpoints such as the rate of GFR decline. But with a slow progressive disease like this one, such endpoints would require very long duration for the trials and very long follow-up. And studies would further be complicated by death from other complications or age. This is not really doable. And so like Tony talked about, this is also a rare disease, which means we simply do not have the statistical power like they had in this DAPA CKD study. And so we don't have enough statistical power to use those gold standard biomarkers. And we really need to find ways to identify patients more likely to reach those clinical and surrogate outcomes quickly, which we don't have yet today. So the next challenge is that the natural history of the disease is still poorly understood. Some reasons for that are the lack of biopsies and kidney imaging data. It would be really critical to develop ways to assess the progression of the dilation phenotype. It would be super useful to understand how this toxic protein accumulates in the human kidney. And finally, would be really, really critical, again, to identify factors to influence slow or fast progression. Then we also have challenges regarding the identification and validation of biomarkers. We need machine learning and artificial intelligence algorithms to classify patients into homogeneous subclasses. There is also a problem of validation of new biomarkers. So every new biomarker needs to be validated. And unfortunately, these often usually have to be done against accepted biomarkers, which are imperfect, such as EGFR or PUN, so gold standard biomarkers. And so you may be tricked into thinking that your biomarkers are simply not efficient, working. And so we have a real issue in validating new biomarkers. And the last challenge is concerns sample types and pre-analytic protocols. And we need to systematically describe the methodology of sample preparation and storage. So pharmacodynamic biomarker. So for a new drug to be approved by the FDA, you have to build a strong trail of scientific evidence to show that your drug modulates its target. And you have to show that modulation of the target changes the morphology of the disease. And finally, you have to show that this produces the adequate clinical effect with no toxicity. And so we are very lucky to have Eliza Thompson from the FDA giving a talk tomorrow to address some of these challenges. At the Broad Institute, we focus on developing this. Oh, I'm sorry. Have you lost my slides? Sorry, people. Something happened with my computer. I'm going to share again. I am sorry, PowerPoint crashed. Okay. Sure. Okay, here we go again. Okay, you can see my slide? Yes, sorry about that. So, as I was saying, at the Broad Institute, we focused on developing this first line of evidence by monitoring the response of mutant MUC1 to our drug candidates. So using those responses experiments in cells and mice, we can assess how much drug is needed to remove the toxic protein and how much of that protein needs to be removed to see an improvement of the kidney phenotype. And this is paving the way for future clinical studies, where the strategy will be to visualize the removal of MUC1 FS in the kidney, potentially through protocol biopsy, and we'll see how this change in the kidney correlates with a change in the urine, so that we can at some point let go of kidney biopsies. And then we'll have to correlate this to changes in the disease morphology. And ultimately, MUC1 FS levels will inform on the optimal, meaning efficacious and safe dose, and the proper treatment schedule to change the morphology of the disease. So I just want to say a few words about assessing urine EVs as a matrix of choice to follow MUC1 FS fluctuations. So us and others have found that MUC1 FS is present in urinary extracellular vesicles, but we also actually detect it in plasma. But we chose to focus on urine because the relevance of urinary EVs as a source of kidney biomarkers is well supported by the literature. About 70% of urinary EV proteome comes from all of the segments of the kidneys and from the urogenital tract as well. And therefore, we hypothesize that MUC1 FS changes in the kidneys will be reflected in urinary EVs. So working with urine presents some advantages, such as easiness of collection, large volumes, EVs being proteins being relatively stable. It presents also some disadvantages, such as intra and inter-individual variability in the composition of urine, which causes issues with normalization between samples. But thankfully, working with EVs mitigates these issues because we can normalize to total protein amount. So in order to measure mutant MUC1 in patients' urine in future clinical studies, we first had to develop a high-performance, clinically applicable quantitative assay. So we teamed up with the Broad Institute proteomics platform headed by Steve Carr to develop a mass spectrometry-based approach called SISCAPA, which stands for Stable Isotope Standards and Capture by Antipeptide Antibodies. So the name sounds a little barbaric, but the principle is actually very simple. This is a method that combines trypsin digestion of your protein samples, urinary EVs in our case, immunoprecipitation of target peptides, in our case, wild type and mutant MUC1 peptides, and then quantitation by targeted mass spectrometry. These assays present many advantages, such as the disruption of all protein-protein interactions. And as you may know, this is a big issue in other antibody-based type of assays, such as ELISA, because target antigens are often masked by protein-protein interactions. The immunoprecipitation step creates exquisite sensitivity and high throughput. You could virtually start from any sample volume, which is perfect for urine. And then the quantitative targeted mass spec provides absolute specificity, true internal standards, and a wide dynamic range. And so again, the assay does not detect and quantify the entire MUC1 protein or MUC1 FS protein. it measures peptides that represent those proteins. So for MUC1-FS, we measure 2 peptides located in the VNTR region, which are repeated a number of times, and that number varies between individuals. For wild-type MUC1, we are measuring 2 peptides located in the C-terminus portion of the protein and repeated only once. So we validated this assay in a cohort of 44 ADTKD MUC1 patients at all stages of the disease, and in 22 related non-genetically affected individuals. We measured MUC1 and MUC1-FS in urinary EV, starting with an input amount of 100 micrograms of urine EVs, which you can obtain from less than 5 ml of urine. The top graphs are showing mutant MUC1 peptides measurements, and you can see that mutant peptides are specifically detected in patients in the attomolar range. The bottom graphs are showing wild-type MUC1 peptide measurements, and we can see that we can multiplex the detection of MUC1 wild-type along with mutant MUC1, which will be a good control to have later for specificity of the drug for mutant MUC1. So we use this data to generate ROC curves, and we see that one of the peptides provides really excellent sensitivity and specificity of detection of MUC1-FS in patients. For the other peptide, our cutoff value had to be higher due to non-specific background, which really lowered the sensitivity. And so we experimented with increasing EV input amounts to see if we could really improve the assay performance. So those graphs here are showing the amount of MUC1-FS peptides detected with increasing EV input amounts. The input samples were generated from 8 pooled control urines and 17 MUC1 patients' urine to obtain a population average. So first you can see a nearly perfect linearity of peptide detection with increasing input amounts, which was super nice to see. And the data that I showed you in the previous 2 slides were generated by this smallest input amount here of 100 micrograms. And you can see that by increasing the input amount, we can really, really push the performance of the assay. And so from that, we learned that future studies should aim at working from an input closer to 500 micrograms here, which corresponds to urine volume starting at about 20 ml. And the last piece of validation that I want to show you is a JQ1 dose response experiment that we performed on patient-derived cells and their matching EVs collected from cell culture medium. JQ1 is a transcriptional inhibitor that represses the expression of both MUC1 wild-type and mutant MUC1. And we found that the assay was capable of measuring a dose-dependent reduction of MUC1-FS in cells in response to drug treatment. And this reduction in the cells was reflected in the EV secreted by those cells in the cell culture medium. So to conclude, we have developed a high-performing assay capable of detecting fluctuations in MUC1-FS level and MUC1 wild-type levels in parallel, which then allowed us to assess our biomarker in the very first clinical study for ADTKD MUC1. And Greg is now going to tell you all about that. Greg, do you want to share?
Yeah. Okay, so hi everyone. So since Julie explained how this assay enabled us to accurately measure MUC1-FS and MUC1 wild type, we thought that it was a good time to do a biomarker clinical trial and test it out. The drug repurposing hub of Broad Institute has a collection of several FDA-approved or orphan drugs, and several of them, actually more than 3,000, were tested in patient cells, and it was evident that vitamin D receptor agonists were able to reduce both MAC1-FS and MAC1 wild-type levels in vitro. Hence, since vitamin D is an over-the-counter food supplement, it would be easy to use it to test these assays for future trials. We had a multi-center trial both in Cyprus and in the US, and we administered cholecalciferol in Cyprus and L-carciferol in the US. In 2019, late 2019, we launched the vitamin D trial in the US. 21 genetically unaffected and 20 ADTKD MAC1 patients were enrolled by Tony Bleyer, and in Cyprus, 46 ADTKD MAC1 patients and 29 genetically unaffected controls were enrolled by Dr. Christoforos Stavro. We administered a single elephant dose of vitamin D, 200,000 units. The endpoint was to quantify urinary and plasma MAC1-FS and MAC1 wild type by using the IMRM CISCAPA assay. The inclusion-exclusion criteria for patients, we set a minimum eGFR to 30. We had to have equally represented males to females, the age range from 18 to 72, and patients shouldn't have any other serious health conditions, not be pregnant or lactating, not nephrolithiasis, osteoporosis or osteopenia, and no hepatic disease. And they should not have been receiving glycocorticoids. Also, they had to be tolerant to the administered supplement, and in case they were receiving any other vitamin supplements, they had to stop for at least 1 month prior to day 0, which was the day we administered the VDRA. And for controls, we set the eGFR at 60, it had to be above 60. In Cyprus, we had the option to include controls that are related to patients, and they were tested negative for this insertion, thus eliminating environmental differences. They shouldn't have any other chronic kidney disease, and their age range should be from 18 to 72 years old. And we tried to have a good stratification of EGR values, both in controls and in patients. Since we're trying to describe the natural history of the disease, we regularly follow a set group of patients, run tests, and this was really helpful, was proven to be really helpful when deciding which patients to include in this trial. This is the protocol of the trial. Basically, during the pretrial period, it was a selection period. Participants were selected, they were informed, and then if everything went well, they had to sign the consent form, and then we implemented the clinical trial in 7 time points. At days 0, 7, and 14, we collected urine, serum, and plasma and run a lot of lab tests that included serum CA15-3, which is essentially MAC1 wild type. And in days -10, 3, 10, and 30, we just collected urine. Cholecalciferol or L-carciferol was administered on day 0, right after each volunteer donated samples. In order to be organized and communicate with our collaborators, we developed a REDCap database, which a lot of you might be familiar with, and it really helped us to collect data on the site and keep trial data really tidy. And Of course, we chose a longitudinal study design and included detailed medical history for every participant. Julie mentioned that pre-analytics are quite important, especially when the biomarker of choice is contained in urine. In Cyprus, we streamlined this procedure, and within 3 hours, the samples were transferred to the lab, were collected, were transferred to the lab, were processed, and then stored at -80 freezers for analysis. While lab tests were submitted right after an appointment of the appointment of each volunteer with Dr. Stab. These are some general results from the trial. You can see how serum vitamin D levels rise after each volunteer was administered with cholecalciferol. The same effect is observed, of course, in both controls and patients. eGFR remained stable after cholecalciferol administration, which was, of course, really good. It didn't have any toxic effect, but what was kind of peculiar was that when studying CA15-3, some patients showed that CA15-3 was a bit elevated after day 0, and then by the time point post-trial 1, which is basically 30 days after, that's 3 months after the trial, CA15-3 returned to basal levels. This was only evident when normalizing each value to the value that patients had at day 0. In controls, this was not evident. In controls, it was not directly evident, but when studying the post-trial time point, you can see that it gets reduced. These are some preliminary results from the CISCAPA assay that from the Cypriot cohort that show the same results. We're still working on it, and samples are still being processed. And since we didn't really know which time point was the most useful to study, we are adding more time points, and hopefully we'll have some solid results really soon. But is measuring MAC1FS and MAC1 wild type enough? Of course, MAC1FS is the neopeptide that we consider as having a central role to disease pathogenesis. And considering that ADTK-MAC1 has a complex biological basis, we might not be able to see how renal function progresses just by measuring MAC1 in urine. Hence, there is an increasing need to discover more biomarkers that might be surrogate, and also try to exploit the clinical data that we've been collecting all these years. Capitalizing on urine extracellular vesicles, I will go through a few of the attempts, a few of the directions that we chose to go in order to discover more biomarkers. Actually, by studying factors that drive disease severity, might be proven to be really a really good option in order to discover robust biomarkers for clinical trials. Reportedly, progression rates are really different between MAC1 patients, even patients that belong to the same family, that are brothers or sisters, and hence we observe inter and intrafamilial heterogeneity. But what are these factors that define severity? How can we classify patients more accurately? We observe that there are two groups of patients. Some of them have a stable progression towards end stage, or they may not even reach end stage, while others progress rapidly. And this is actually the standard in many renal diseases. Of course, we do have this mid-gray zone that we don't really know how the disease will develop in that group. Hence, we formed two groups, one having stable progressors and the other one having rapid progressors. And try to discover more biomarkers. There is an ongoing effort to discover more biomarkers, and besides the long follow-up, I will mention how we study urinary EVs and also how we try to use historical clinical data. We have recently started implementing an ambitious project where we are isolating proteins, RNA, and metabolites from urinary extracellular vesicles. And by using proteomics, transcriptomics, and metabolomics, respectively, we're trying to bring all this together and do a multi-omics approach in order to come up with good surrogate biomarkers and also facilitate prognosis and classify patients more confidently and eventually use them as clinical trial endpoints. Here are some results from the proteomic profiling in urinary EVs, where we use 7 rapid and 7 stable progressors. The experiment was run in discovery mode, and you can see that the two groups can be classified. And when you compare the two groups, there are unique protein signatures that we are still trying to explore and increase our confidence in them. Of course, we got a lot of vesicle-associated proteins, while urothelial, podocyte, and tubular proteins were also present. And here you can see that both MAC1 and UMOD are present in these vesicles, and actually there is no difference when you compare rapid to stable progressors. We also we can also see that the urinary EV protein load includes exosomal markers like LAMP1, CD63, and of course annexins. What was remarkable, though, is that rapid progressors were the ones that had TMED9 in urinary EVs. We know from Dvela-Levid et al., the paper that was published in Cell, that TMED9 vesicles are the ones that carry the frame-shift MAC1 protein. And this was also evident in urinary extracellular vesicles, together with other proteins like CRP, that is also only present in patients, while sialoadhesin, that is a molecule that we know it interacts with MAC1, is only evident in stable progressors. To do transcriptomics in urinary EVs, we chose to, after isolating them, run next-generation sequencing, and you used a UMI-based protocol where each microRNA is tagged with a different barcode. Hence, it makes the analysis much more accurate. And after analyzing the results, the first results, we came up with a lot of microRNAs as well as piRNAs. Here you can see a heat map of rapid progressors versus slow progressors, and there are a number of microRNAs that are represented in either group. And in these vesicles, we were able to find markers that are microRNAs, which signify either the thin ascending limb of Henle's loop or the collecting duct and general tubular cells. But then there has to be a way to see if when a patient receives a therapeutic intervention, how does the kidney respond? And we, of course, know that eGFR is the way to see how the renal function progresses. But if you go through all the data that you might have from a patient, you will see that eGFR values fluctuate, and this confuses statistical models. Hence, it's really problematic and it's really difficult to define disease progression rates. Most of the data that clinicians have are non-continuous or they may be limited, while some correlation analysis that people usually do are not adequate. And when classifying patients to rapid or stable progressors, for example, this is usually biased, and it would be good to have a way to classify patient groups by using eGFR values, but this to be done through something else, a different approach. There are other factors that might influence disease outcomes, like food intake or hypertension or uric acid, while it takes several years to draw conclusions. You have to follow, and especially for a rare disease, you have to follow patients for years before you understand how their renal function behaves and how it progresses. Hence, it's impossible to predict how eGFR rates progress. And that's a severe limitation for clinical trials. So there is a need to enable forecasting for eGFR values, and this will in turn make the duration of clinical trials shorter. Therefore, we implemented mathematical models and machine learning approaches to help classify patients into categories of progression and eventually predict disease outcomes. This will, of course, be an unbiased classification of patients, and it will help us select individuals that will be better participants in trials. Of course, our aim is to do forecasting, and we will have the input from by a nephrologist in order to train models through machine learning. Therefore, we collected non-continuous data from more than 130 Cypriot patients that go back around 40 years, and we used multiple variables. So it was eGFR, uric acid, and urea. If this works out, it will be the definite biomarker to monitor how renal function responds to therapy. In order to transform non-continuous data to continuous, we used a Euclidean model, which works by defining the distance between sequential data points. These data points were set as 6 months. So we started from 18 to 80 years old, and then we set theoretical time points every 6 months. We included patients that had at least 3 measurements in 3 years, and we also included patients that underwent transplantation or are in end stage. This approach, paired with machine learning, will help in patient classification and help us classify how gray zone patients will behave in the future. And this, of course, will facilitate biomarker discovery efforts. Also, through forecasting, we will be able to predict how the renal function will behave in every 6 months. This will in turn help prospective clinical trials, will shorten them, and it will be a good approach to follow in order to study how a drug can alter, can worsen or make better renal function. So that's all from us. Thank you very much. And a great thanks goes out to all our collaborators that are too many to be on this slide. Thank you.
Wow, thank you so much. I mean, biomarkers, I mean, it's an understatement to talk about, to indicate the critical nature of biomarkers in getting closer and closer to a treatment and a cure here. So thank you to you both so much. What a profound keynote. And there's some questions that have come in, and we'll address those a little later as well, but really appreciate it. And we'll move right along here to Masha. Let's make sure. Just want to make sure we've got. Oh yeah, oh great, oh yeah, perfect. Masha's on.
I'm here.
Okay, good. I just want to make sure I didn't. And so we'll move right into to Masha's talk, who again Anna's already introduced. And so with no further ado, take it away.
Okay, thank you so much for inviting me and presenting my favorite topic about high content imaging, how it powers discoveries in MKD. Just a second, please. Okay, can you see my slides? Okay, thank you. So I'm presenting work, of course, not my own, but the whole MAC1 team, and very much, we worked very much together with Moran in past. So that's a big part of her work here. Okay, I first would like to talk about high content imaging itself. And I would like to show what is high content imaging on the example of one high content screen run, so-called. So this is a one experiment which is performed usually during 1 week. So in this run experiment, cells are seated in 384 well plates. And during one screen, they are treated by up to 3,000 drugs or any other conditions. After this treatment, the cells are stained with up to 4 fluorescently labeled antibodies. And I have to mention that with the help of our automation team, we delivered a really fully automated protocol for this staining. So we can use up to 30 plates per screening run simultaneously. The plates, after they are delivered to our high throughput confocal imaging instrument, Opera Phoenix. This instrument allows acquisition of cell images with high speed and high quality. During one screen run, we can obtain up to 300,000 images. In every image, single cells can be segmented based on their staining, and this provides us with analysis of about 50 million cells per run. Now, from each of these cells, we can extract dozens of different image analysis parameters. And then all these parameters, as a result, are delivered as a high content information for interpretation. Now, let's go back again to little history. So about 6 years ago, I joined the Broad team. And our goal at this time was to better understand a rare kidney disease that is now called ADTKD MAC1, and hopefully to find a treatment. At this time, it was discovered that the disease is caused by a mutation in MAC1 gene, and it was presented before pretty well in other meetings. So I don't go into this. But it was very little known about the mechanism of this disease development. So I will present only a small part of the whole team work, which is related to high content imaging. And I will mainly try to making a long story short on certain aspects of this study. We used 3 models for our study. The first model was a cell obtained from patient kidney. In all pictures here, the mutant MAC1 will be shown in green, as you can see here, and a wild type MAC1 will be shown in red. The second model was a mouse model. In this model, the mutant MAC1 frame shift was knocked into one of the mouse MAC1 alleles. And the third model was a kidney organoid, which is a mini kidney developed in vitro from patient and normal and control blood cells. These organoids have provided a great opportunity for us to analyze and even perturb cells in the state which is quite close to a real human kidney, which is really rare opportunity. And like from all these pictures, you can see that MAC1 wild type is delivered to its original location, which is apical membrane in the tubules, plasma membrane in the cell, and MAC1 frameshift is accumulated somewhere inside the cells in a vesicle-like structures. So the question where this frameshift accumulates. In order to answer this question, we performed colocalization study. MAC1 protein has a signal that directs it for translation in ER area. So from this ER, the protein is trafficked through the early secretory pathway to Golgi, where it is glycosylated and then moved to its plasma membrane destination. We've therefore performed a thorough secretory pathway localization study in which we wanted to figure out where on this pathway frameshift protein is stacked. In order to do it, we selected a number of IF probes which represented different compartments of trafficking pathway in a cell. Each probe was labeled red and analyzed in a cell together with frameshift signal, which is green. We performed image analysis, which allowed us to calculate colocalization of these two probes and measure the extent of this colocalization. And finally, we showed that frameshift is basically distributed all over the trafficking compartments, but the biggest part of it is colocalized and trapped within the vesicles, which were positive for TMED9 protein. TMED9, again, we don't go into details about this, but shortly, TMED9 is a cargo receptor playing not very well understood until now role in trafficking between ER and Golgi. In a further study, we showed that MAC1 frameshift colocalizes with TMED9 positive vesicles in all our models. And then we also asked whether the presence of TMED9 is essential or it's just a satellite for FS accumulation. And the answer to this question came from knockout study. So if you knock out TMED9, then you fully remove MAC1 frameshift without any effect on MAC1 wild type. Again, there is a lot of work done on this mechanism of action, but I will not go into this. I just will say that we continue working on this mechanism. Another question we explored was what pathology is related to MAC1 FS accumulation. In our mouse model, we observed that the proximal kidney tubules located in the outer medulla of mouse kidney were severely dilated by mouse age or approximately 1 year old. And these damaged tubules were accumulating frameshift protein as seen here in green color. So the question appeared where when this pathology develops in natural history of these mice, and how can we measure it, and how can we use it for our further therapeutic studies? So in order to identify this phenotype, kidney section was stained for 4 markers. Of course, MAC1 frameshift protein, LTL, which stains proximal tubules, DAPI, which stains all cells, and NCC for distal tubules. Then we developed an image analysis pipeline, which used the computer learning approach to identify different areas of kidney, including outer medulla shown here in red, where this pathology phenotype develops. As I mentioned above, 4 markers were used in this experiment. DAPI helped to identify single cells in this tissue section. MAC1 frame shift was measured in each of these cells. And then NCC positive cells, as shown here, or LTL positive cells within outer medulla were detected in order to focus our frame shift measurement on very narrow and homogeneous and also biologically relevant cell populations. In order to measure the tubule dilation phenotype, we focused our analysis on previously identified outer medulla area. In this area, potential tubules were selected by computer, and then we used computer learning approach to teach the software to select the real tubules which were satisfied our visual criteria. And then the width of each of these tubule was calculated and averaged per outer medulla area. As you can see here, frame shift signal is accumulated in outer medulla in 3-month-old animals, female mice. But tubular size, which is seen here within this rainbow squares, looks similar in wild type and frame shift mouse. At the age 5 months old, you can appreciate the difference in tubular size in mutant mouse in some samples. Our measurement revealed that even though the dilation is continuously happening during the mice aging, the change is happening more drastically between age of 4 months old and 5 months old. And this suggested us that this period can be the most appropriate time for future drug treatment experiments. Okay, coming to the drugs. So now is the second part of this presentation related to the drug discovery. In order to find a drug which would disrupt the frame shift trapping and promote its degradation, we used high content imaging assay in which in one experiment we could measure 3 parameters. The first, of course, is frame shift itself, which is seen here in green. Then wild type, which is orange here, to find a drug which will specifically remove frame shift signal and does not interfere with wild type protein. And the third parameter is cell number, measured by nuclear staining, to exclude the compounds or compound concentrations which cause cell toxicity. We have chosen to screen a broad repurposing set in a hope to find a drug which from one side will be easy to repurpose for our disease treatment, and from the other side, because all these drugs, or at least majority of them, are well annotated in this library, we hope to find a compound with a known mechanism of action, and thus to discover an appropriate target protein for our future study. As a result of our primary and secondary screen, and also a couple of profiling assays like a viability assay, qPCR, lysosomal colocalization, we came with our best candidate, BRD4780. BRD4780, you can see here the results of the whole screen. So you can see that there are many drugs which are shown in gray spots right here. They are removing frame shift signal, but they don't change the frame shift to wild type ratio, so which means that they remove wild type as well. And there were not so many which showed removal of frame shift, but not wild type signal. And one of these was BRD47, one of the most active compounds here. These dose response curves show how all these 3 parameters, which measure frame shift, wild type, and cell number, can be represented and reported simultaneously in our drug discovery pipeline. Julie already showed this slide. So basically it shows that this compound removes frame shift protein from 3 different models very efficiently. So basically bringing the level almost to the control samples. Now, perhaps the most important finding is shown here. If you treat mice during 3 months within the age range, which I was talking about earlier, not only frame shift is removed from the kidney cell, as you can see here, but also the dilation phenotype is reduced significantly, even using the lowest dose of our compound of 30 mpk per day. This dose didn't remove frame shift fully, but showed good results for pathology phenotype. And it opened possibility that even lower dose taken for longer time can give us probably good therapeutic effect. So that's where I would like to conclude, saying that we are continuing working on our drug mechanism of action, as well as a mechanism of all this TMAT involvement. And I would like to thank the whole team, and especially, of course, Moran, from a former member of Anna's lab, and also Keith and Matt and Alisa, who worked on this project, and from CDOT and from imaging team, Michelle and Patrick, and all former members of CDOT or Anna Greka lab, all our collaborators, and of course, all MKD patients, which generously donated the samples for this study. Thank you very much.
Thank you. Yeah, very, very well done, and always tricky. We're so always tricky to communicate things effectively, and just so beautifully done there in a short amount of time. Thank you so much. Well, again, Anna has kind of introduced everybody, and everyone has the agenda. So we'll move right into our next segment, all the way from Newcastle, and take it away on biopsy, Eric.
Yeah, thank you very much. So good morning for everyone. Thank you very much for inviting me for this presentation, where Anna and Tony asked me to review the applicability, or the theoretical applicability of protocol biopsies in the field of ADTKD, and also to see whether there are precedent interventional trials that have used maybe mechanistic targets as a readout or primary readout in interventional trials. So this is a little bit more on philosophical expose, where we go to different evidence. So first I want to remind you what is the current evidence that ADTKD, UMOD, and MAC1 are storage disorders, and what is the evidence that this storage is actually toxic, which will have implications when choosing a readout, because this means that it is a readout that informs about disease progression. Secondly, we will speak about general considerations regarding protocol biopsies in ADTKD, and then I give some examples of interventional trials in nephrology, but also in other fields that use protocol biopsies as a primary outcome measure. So we are well aware of the clinical presentation of ADTKD. I just want to highlight here that it's a silent disease that offers very little to look for progression or to monitor response to drugs. So we have a slow decrease of GFR, but there's no proteinuria to measure. There's no increase in kidney sizes or cysts like an ADPKD that can be monitored as an outcome measure. And also the biopsy does not give very much buffer. So we have interstitial fibrosis and tubular atrophy, but there's no international classification system for these disorders that could help to standardize biopsies before and after drugs. And the last thing that might be relevant for intervention trials is that the diagnosis of this disease requires the demonstration of a genetic mutation. So that's also important for enrollment in clinical trials. Now we will speak mostly about ADTKD, UMOD, and MAC1, which are the main genetic causes for ADTKD. And the really striking event that we observe in the cells of these patients, in the finger-standing limb or other cells, is accumulation of mutant UMOD in the ER, or ADTKD UMOD, and accumulation of mutant MAC1 in the ER Golgi intermediate compartment for MAC1, as shown by the work of Greka. So this really shows or suggests that it's a storage disease. And more than that, we also have evidence that ADTKD in general is a paradigmatic disease for the role of proteostasis in kidney disease, because several of these disorders have roles in proteostasis, so the homeostasis of proteins. As an example, so SEC61A1 is a translocone protein for the ER translocation. DNAGB11 is a quality control protein in the ER, and also renin accumulates at different levels of the ER. These disorders are really exemplary and paradigmatic for the role of proteostasis in the risk for CKD. So let's review now the evidence that ADTKD UMOD is a gain of function disorder where the accumulation of mutant UMOD is actually toxic for the kidney. And most evidence comes from animal models. And we know that if we remove UMOD completely from animals, these mice do not present with kidney disease. In contrast, in this strong evidence, several models of animals where you introduce mutant UMOD both recapitulate the phenotype of humans, but also the accumulation of mutant UMOD in the endoplasmic reticulum. And this is associated with the with upregulation of unfolded protein response, which also can be seen in human biopsies. And then there's somewhat indirect evidence. So these are missense mutations in these patients, while there's population genetics evidence that loss of function variants are well tolerated. And also there's some kind of correlation between the amount that mutations accumulate in the ER in vitro and the clinical severity of the disease. But as far as I'm aware of, the last piece of evidence is still missing, which is actually that modifying accumulation of UMOD or acting directly on the unfolded protein response rescues the disease in vivo. That is still missing. And so I forgot to mention also here these pictures just to show you as an example what you see in biopsies of patients. So you see that normally you have apical UMOD in a normal biopsy, while in the disease you have accumulation of UMOD throughout the cell. And you can co-stain this by IF with a marker for the endoplasmic reticulum to show that it's or suggestive that it's in the ER. And for those that don't believe this, we can also look at electron microscopy where we see really accumulation of this substance in very large hyperplastic ERs. So it's an ER storage disease. The situation is similar for ADTKD MAC1. So we have the luxury here to have an antibody that recognizes selectively the frame-shifted MAC1. For UMOD, it's not the case. So the antibody recognizes both mutant and wild-type UMOD. But here we see that frame-shifted MAC1 accumulates in the kidneys, but also in other cells of patients with MAC1 mutations. And this is not seen in control samples. Also here, the knockout and of course the accumulation is, as we have seen before, in the early secretory pathway, as has been beautifully shown before. The knockout mice also here do not have any disease, but the frame shift expressing mice develop slow kidney disease. And this leads also to upregulation of probably adaptive UPR and susceptibility to apoptosis. But we have also to know or to remember that we have also accumulation of this frame-shifted protein in other tissues, and there it does not lead to disease manifestations. So that's a little caveat. And at least it's not published, but we have seen just now that evidence is there that you can act on the frame-shifted MAC1 and rescue the phenotype in preclinical models. This is very important evidence, of course. And so the drug, as we have known, so we're not going to this detail, but in a dose-dependent way in the kidney by immunofluorescence, you can monitor the rescue of the frame-shifted MAC1, but also, and these are preliminary data in the same paper, where in cell models, so in vitro, expression of mutant UMOD, and this is a mutation that has been shown to cause disease in humans, and for which also an animal model is existing. So this mutant UMOD can be rescued to a certain extent by the drug in vitro. But there are no evidence yet in the literature for rescuing also preclinical models. So a few general considerations regarding safety of these protocol biopsies. So protocol biopsies have been mostly used in the context of transplantation. There it is standard of care that after different time intervals, you biopsy the transplant kidney and to check for subclinical rejections. And you have to know that biopsy of a transplant kidney is easier than a native kidney. So in the field of transplant kidneys, there have been studies comparing indication biopsies with protocol biopsies, and the rate of severe adverse effects are very similar. They are around 1% for transplant kidneys, and we know that for native kidneys, depending on who does it and the centers, the rate of severe adverse effects like major bleedings, transfusions, or other hospital admissions can go up to 5%. So there is a certain risk with this. But we also know that in protocol biopsies, the safety standards are much more stringent. So you would not do a biopsy for someone where you cannot interrupt, for instance, anticoagulation and so on. Then we have to speak about what is the potential readout in this disease. And as seen before, there is no international classification for the histological changes in ADTKD. And we also do not know to what extent the fibrotic changes are reversible. We know that there's a certain plasticity from animal models of mostly of ADTKD, of fibrotic changes, but we do not know what is the time course for this and whether also in ADTKD these changes are reversible. So for these reasons, it's probably safe to assume that a good readout on these biopsies for ADTKD would be mutant UMOD and MAC1. And then there are several questions. So what are the techniques? So IF probably, but also, as we have seen before, maybe proteomic approaches on tissue. We have for MAC1 a specific antibody for the frame-shifted protein. So probably it would be easier to have a standardized approach to quantify removal of frame-shifted MAC1 versus in UMOD. It would be a little bit more tricky because you have always big amounts of UMOD, and we have to separate between what is in the ER, what is stored, and what comes to the membrane. So this will require co-staining to know where we are in the nephron, and also to co-stain probably with organelle markers in the case of UMOD, and probably will require, as we have seen before, computer learning algorithms to assess these changes. And then also standardization between centers for a multi-center protocol. The possibility is also to use other readouts, such as ER stress or inflammation, although we do not know whether there's differences between mutation, in particular for UMOD, between the axis of ER stress and so on. So that's something that is more shaky. And as we have seen very beautifully with extracellular vesicles, there might be also less invasive alternatives to use as a readout. Now, just to open the field now on protocol biopsies, so really to show you that the richness of these biopsies and how they really open the area of precision medicine. So I show you just here the Kidney Precision Medicine Project, which is an ongoing project, which is multi-center and prospective, investigating adults with common causes of CKD and acute kidney injury. And in this protocol, in this study, a protocol kidney biopsy is required for every patient that is enrolled. This patient is then followed up for 10 years. Different readouts from these biopsies are integrated. So this is traditional pathology, but also more modern omics approaches together with clinical data. And the goal of this study is really to redefine the landscape of these common diseases at a molecular level. And they make the most broad use of these biopsies. So there's always a pipeline, one core that goes to traditional clinical assessment, with a report that goes back to the patient, which might or might not be clinically relevant, mostly not probably for this kind of cohort. And then there are two cores that are in parallel processed for all these omics approaches. So that's really to show you the importance that the biopsy is taking in precision medicine. If we go to clinicaltrial.gov and we look for interventional trials in the field of nephrology, where biopsies are taken as an outcome measure, we found 230 trials registered, and the large majority are in the setting of transplantation or carcinoma. If we look for other settings, most of them are looking for glomerular changes, and for most of them, the biopsy is a secondary outcome. So it's not really something that is a primary outcome. And I show you two examples here in IgA nephropathy, where a secondary outcome is the change in mesangial hypercellularity and renal biopsy. And the advantage here is, as mentioned before, that there are very well established classification systems existing to classify these biopsies on an histological level. And this is not existing for UMODs. There's an advantage for glomulopathies that is not existing for ADTKD. And here's another example in type 2 diabetes, where they use a little more modern approaches, also RNA sequencing on the biopsy. However, I think that what is probably most close to the scenario that we have here is what has been done very beautifully in Fabry disease. So Fabry disease is a multi-system lysosomal storage disease that is characterized by the deficiency of an enzyme that is called alpha-galactosidase A. And this leads to the buildup of a glycolipid that will be referred to here as GL3, so globotriazole ceramide. And this is a lysosomal storage. And these studies have looked at the removal of this GL3 after different interventions. So I show you here an early study from 2001, where human recombinant alpha-galactosidase A was administered in a multi-center randomized placebo-controlled and double-blind study of 58 patients, and over a time period of 20 weeks. And so the primary outcome here was to look at biopsies and to see the percentage of patients in whom these deposits of GL3 have been cleared from the endothelium of the kidney. And secondary outcomes were also to look at the same changes in the heart and the skin, also by biopsies. And a little bit to go more in detail. So biopsies of the kidney, the heart, and punch biopsies of the skin have been taken at baseline at week 20, so after the trial, and also after 6 months of an extension open label trial. And then these tissues have been stained and assessed in a blinded fashion by 3 pathologists per organ, and were scored. So they had established a semi-quantitative scoring system and were scored from 0 to 3, depending on how many of these GL3 remain in the biopsy. And the primary efficacy endpoint in this study was over 50% of the capillaries without any deposit, and less than 5% with a score of 1 or greater, and the rest only with trace evidence of GL3. And this is really a landmark paper, and you can see here how nicely administration of this enzyme reduces the scores in the kidney, in the heart, and also in the skin. So a highly important study. There's a second landmark paper in the field, again of Fabry disease, where this time not an enzyme was administered, but a chaperone, so an oral drug that helps to stabilize some mutants of alpha-galactosidase A. In this case, also a double-blind, randomized, and placebo-controlled studies. And the primary outcome was, again, the levels of GL3 in the kidney as assessed by deposits in interstitial capillaries. So indeed, it is more or less the same group that did also this study. Interesting is that they did an inclusion criteria where the mutant form had to be responsive to the drug prior to the testing in vitro. And this could be interesting for UMOD, where we have a large number of mutations, and some might be more responsive to the drugs than others. Also in this case, so there was biopsies in the beginning, after 6 months and after 12 months. And the evaluation were multiple. So they looked at the percentage of participants where there was 50% of reduction in these inclusions, but also inside each patient, the percentage of change of deposition at different time points. And again, 3 blinded pathologists, 1 pathologist that annotates 300 capillaries, and 2 other pathologists that scored these capillaries. And they also report some adverse effects to the biopsies, and this was mainly procedural pain in 11% of cases, and hematuria that might or might not be related to the biopsy in 3% of cases. Then I found this study that might be relevant and interesting. Here we are now in the liver this time, and we're looking in a disease that is called alpha-1 antitrypsin deficiency, which is caused by homozygous missense mutations in a gene that is called SERPINA1. And that disease is causing a lung emphysema by a loss of function effect. So the absence of the enzyme causes lung emphysema, but in the liver, the accumulation in the ER of this enzyme actually causes a gain of function effect and liver fibrosis. And so this group here was investigating whether carbamazepine, so an FDA-approved drug for convulsions and as a mood stabilizer, actually can increase autophagy in the cells and can help to rescue misfolded and accumulated protein from liver cells. And that's a small study with only 20 subjects receiving the drug and 10 subjects receiving the placebo. And we had to look for the effect of the drug on the hepatic load of the mutant protein and the effect of the drug on hepatic fibrosis. So also a fibrotic endpoint after 1 year of drug administration. And so basically, one difference is that liver biopsies in this context are part of the standard of care for adults. So it's not really a protocol biopsy. It's also to some extent an indication biopsy. And what he looked at were pus stainings indicating mutant protein in the area of liver sections that are occupied by these globules, and also performed or proposed to perform Western blots for mutant protein. And the fibrosis is assessed by serious red stains and concentration of hydroxyproline. However, they don't provide any further information on evaluations. That was an interesting study where there's a lot of similarities with UMAT in particular. And then, without going in detail about the field, where really protocol biopsies are important, and especially with respect to mechanistic readouts and protein readouts, is the field of Duchenne muscular dystrophy, where several groups are looking at the reappearance of dystrophin on the biopsies, on muscle biopsies, after exon skipping therapies, for instance. So that's really something where the protocol biopsies has a lot of importance and where we could also look for protocols. So to conclude, I think I want to show here that ADTKD storage diseases are a paradigm of diseases where it is rational to intervene on the clearance of mutant protein, but also to reduce protein production overall. That preclinical models are really helpful to establish strongly the link between accumulation of mutant protein and disease progression, and also the way to rescue disease progression by rescuing mutant protein, and what is the best time frame to do so. To propose mutant human and MAC1 as probably the best readout for protocol biopsies, and that Fabry disease studies have set the precedent for these clearance studies and protocol biopsies in the field of nephrology. So I would like to thank you very much for your attention, and I'm happy to take questions.
Thank you so much. That's a fantastic update, and again, always love hearing from the researchers and collaborators from all over the world. We're now going to jump into a Q&A section. We have some in the Q&A module on Zoom. You can see that there have been some questions asked and some answered already. Feel free to add additional questions there. You can also just use the raise hand functionality and ask a live question. But let's dive in. There are a few questions for Dr. Bleyer that we can start with, and I'll just kind of moderate these, and if you want to answer them. So from Anne Scheidler, thank you so much for this exciting talk, Tony. Is the decrease in EGFR reversible after discontinuation of the SGLT2 inhibitor?
Yes, that's been shown in many studies. So yeah, so it's kind of like you're taking the pressure off the kidney, you're decreasing the GFR, and then if you get rid of it, if you stop the medicine, it'll go back up.
Great, thank you. Another one for you from Stephen Hayden. Given the high risk, should MUC1 patients who are negative for COVID antibodies receive pre-exposure prophylaxis through monoclonal antibodies?
I didn't quite understand. I think if MUC1, if any ADTKD patients, especially transplant patients, Well, I should say, any ADTKD patients with chronic kidney disease or who are transplanted, who are greater than 60, if they're exposed to COVID, they have a real exposure, you know, their coworker has COVID who's in the same office space, then they should get monoclonal antibody treatment. If you have a family member that gets COVID, you should get it if they live with you. And if a patient with ADTKD who has chronic kidney disease gets COVID, they should try to get monoclonal antibody right away.
Great, thank you so much. Another question from Helene Hughes. What scientific paper, you know, this was asked during your session, so I assume it's for you, but maybe others have opinions too. What scientific paper should I tell my nephrologist about? So should I figure out if I was able to try, okay, this is where I'm.
Oh, if you could try the SGLT2 inhibitors.
Yeah,
yes.
Sorry. Like
The answer to that is yes. If you can email me, we can send you a copy of our abstract, and we can also send you a copy of a link to our webinar about SGLT2 inhibitors. And you can provide that to the doctor. And I'd be happy to talk to the doctor as well.
Great. Another question from Ann Scheidler. In which cases would you stop the treatment with SGLT2 inhibitor? Are there hard indicators?
I don't think there are hard indicators. I think some patients can have like a really significant drop in GFR. And so if patients seem to be progressing rapidly, you could stop it. I would say a GFR decline of greater than 20%. But a lot of it, the problem with these medicines is that the patients that we had who went on the trial, they were really following their kidney function very, very closely. And then when they had a 10% drop in the GFR, even though we anticipated this, a lot of them just stopped taking the medicine. So if you were thinking of taking SGLT2 inhibitors, you have to go into it really thinking that you're going to see a 10 to 15% drop in GFR over the first 3 months. But it's all saved. That's not function that's lost. It's all saved. I like to say it's kind of like, you know, any of you have rented a truck. If you rent a Ryder truck, it'll only go 60 miles an hour. That's the fastest it'll go. And, you know, so I think of it, well, maybe that's saving the engine. And if I took that regulator off that Ryder truck, then I could go faster whenever I took it off. And in the same way, these medicines just lower the GFR mechanically. And then if you remove them, the GFR goes back up. And we showed that in all the patients in our study. Once they came off the medicine, the GFR went right back up to where it had been before.
Thank you so much. We had another question from Cynthia Hahn, and this was during, it may be for Tony or maybe for Julie and Greg too. It's given kind of at the beginning of their presentation, but maybe each of you can weigh in. What is thought to be the mechanism by which a rise in HCT is associated with or predictive of efficacy of SGLT2 inhibitors, if I'm understanding this correctly? Is the opposite also true? Does a lack of rise predict a poor outcome or efficacy?
Yeah, I can take that. So I think this is the data that I talked about from Dr. Vonner. And we're waiting to see this get published. It's kind of preliminary data. And I would be interested to see if in general, if they think that patients on these medicines should stop them if the hematocrit does not go up. How does it do this? I think there are a number of potential mechanisms. I think they said they think it has something to do with hemoconcentration of the blood so that you have more urine output, but I don't think it's that. I think it has some effect on what we call the macula densa, which is where all of these things interact. And I think it just changes your ability to make hormones that keep the hemoglobin, make it go up. If you did not have a rise in hemoglobin, I would not worry about it. I would just stay on these medicines and just see how things go over time. I would say one thing about the SGLT2 inhibitors. In every group, that these medicines have been studied in. They've been shown to be effective in diabetic patients, first of all, with protein in the urine, and diabetic patients without protein in the urine, and patients with just generic kidney disease with protein in the urine, even with limited protein in the urine, and patients with advanced chronic kidney disease. Then they split out patients who had IgA nephropathy, another type of kidney disease, and they showed an advantage in them. And then when they do the subgroup analyses where they say, look at women versus men, look at, obese versus non-obese, look at different subgroups, they always seem to work. So it'd be really, really bad luck if they don't work in our disease. And I'm hoping that's not the case. And my thought is we're just trying, what I don't want to have happen is have patients who right now I have stage 3 and stage 4 kidney disease, and they're progressing on to dialysis. And I don't, want to say, okay, well, we're going to have more data in 5 years. And then these patients will be on dialysis and they'll have missed any opportunity. And so what I would rather do is say these drugs are at a very low risk, and especially with monitoring. And since they're at low risk, if you get followed up closely with them, I think it's reasonable to try them and see. And I think there's going to be a lot more data coming out in the next year or 2 or 3 on these agents, but it may be too late for a lot of our patients who are progressing.
Great, thanks so much. We have another question from the chat.
Oh, can I just say one other thing, just very quickly? This is the use of these drugs are indicated in chronic kidney disease. However, I'm not advocating them to you personally as patients. I think you need to have a decision with your doctor. You need to talk to your doctor about that. We're happy to provide our abstract. I don't work for these companies or get promoted by these companies. So I think it's really a decision between you and your doctor, but we're happy to provide the data that we've accumulated.
Thank you. I'm gonna read one more question that came in from the chat, and then we'll take some live questions too. If you want to raise your hand, use the raise hand functionality. We'll turn on your audio and video, and you can ask live questions as well. But this is directed to, and again, I think this was during Julie and Greg's presentation. Can the panel provide more background on the prevalence of fast versus stable progressors? Overall percentages of each in the MUC1 community, any differences by geography, any evidence that a stable progressor converts to a fast progressor or vice versa? Who wants to take that one?
Greg.
Yeah, I did answer that question actually. Yeah, of course, we observe a geographical distribution of patients having either a more severe disease or a milder disease. For example, in Cyprus, the disease is thought to have a milder course. We have a later onset compared to Tony's data. But it's really difficult to segregate these people into progression groups. Some of them are, it's quite obvious if they are rapid or stable progressors, but others not so much. So we are trying to make better groups in order to help biomarker discovery. So it's impossible to say a number or decide what the prevalence is in each one of these groups. We cannot really tell what's going on at the moment. We're working on it.
I'd like to second that. And so one thing that's really, and when we ask our patients for this data, but as many serum creatinine values as you have, if you can get them to us from before dialysis or before transplant, because this is data that you need thousands of creatinine values over time to make any sense of. So, and I'm sure Greg is in agreement that, if you were on, let's just say you're 40, 50 and you were transplanted 2 years ago, if you could go back and get your creatinines from as far back as possible from when you were 20, that type of data is extremely helpful for us. And the other thing that can be helpful is that if you you know, if you say to us, well, you can contact my doctor to get the records, that's helpful, but that takes a lot of time for us. And if you want to help our research effort, if you send us, you know, a list of dates and serum creatinines for yourself, that really, these are things that our patients can do that can really push forward the research. And just one other comment, the rate of decline, like Greg is saying, of kidney disease is just not linear. And it's really frustrating because not some years, like we may have patients their GFR goes down, like, or let's just say their creatinine goes up from like, say, let's just say 100 to 150, or from 1.5 to 2 in a year. And we're like, oh my gosh, they're going to do terrible. But then over the next 3 years, they may stay at 2. And so why does that happen? And you can see with these changes, ups and downs in GFRs, it makes it difficult. And that's why we're doing our longitudinal study. And we're also, like Greg, we're analyzing our data. I'm a little jealous because Greg is doing a better job than us. So that's a good thing about this, because it's gonna get me a little bit more motivated that we work harder on this. And we collaborate with Greg, so this is kind of
course.
we share data. And the good thing is Greg can take his findings and what we call validate them in our data. So he can say, wow, I found this works really well, these markers, which I'm really excited about, the urinary markers. And we can send him our samples and he can see if in another population it works.
And I would like to also comment that there's usually great variability between nephrologists. So we are extremely lucky to have Dr. Stavro in our group, and patients that are really responsive and engaged, and they would do as much as they can to help us out, because at the end it goes back to them, it returns to them. So it's a really hard task to gather all these values and go back all these years, but we're working on it again.
I'd like to say about Dr. Stavro, you know, I've studied this disease for a long time and people ask me a lot of questions, but I cut my teeth and learned all about this from reading his earliest papers, which were just led the way, really.
Thank you. And Dr. Greka had a question or comment.
Yes, well, this has been a tremendous series of conversations, and I just wanted to take a second to celebrate the fact that we have patients and the patient organization moderating this amazing session with physicians and scientists. Masha, Julie, Kendra, Eric, Greg, and Tony, of course, have been tremendous in informing us throughout the morning. I can't help but notice that we actually are very lucky to have Eliza Thompson with us here today. And so I wanted to take this opportunity, if I could, and also given Eric's wonderful discussion, to really ask perhaps kind of a more provocative question, or just a question around, you know, how would Eliza think about, and I know we're going to hear from you tomorrow, Eliza, about the FDA's approach to rare diseases and rare kidney diseases, but just thinking about protocol biopsies or all the biomarker work that's going on in these rare kidney diseases, how would one think about what Eric presented from other examples where this has been used, and what we might learn that could be useful for this community.
Sure, and I hopefully you can hear me. I wasn't actually, I assumed I was in the audience today. And just
sorry to put you on the spot. I'm sorry.
No, it's absolutely fine. I just want to turn my camera on. Again, hopefully all of you can hear me. Just want to say it's really exciting to see all the work that's being done, because I think fundamentally to get a new therapy to market, it needs to be based on science. And I think especially if you're in the setting of a rare disease, frankly, you guys have to be smarter than everyone else. And so it's great to see that you've got a team of really smart people who are thinking about these issues, who are trying to understand, essentially what we call and develop what we call our tools. We call them drug development tools, but they're the same tools that you use in clinical practice. I think that patients need to try and understand, okay, I have a disease, what's going to happen to me, right? And then also to help ultimately find the treatments and figure out if these treatments are going to be effective. So, I'm not necessarily directly answering your question, but do want to emphasize that it's really exciting to see that you're focusing on the science and that you're focusing on defining the natural history of the disease, trying to figure out the markers, things you can measure in the blood or urine that tell you who's likely to progress and maybe who's less likely to progress. All of this is critical for successful drug development. And as well as, some of these things, if we understand the disease process well enough and causation and other things can be used as our endpoints. Because waiting to get to kidney failure, we can't do a trial long enough to look at that as an outcome. So we're going to need to be using things we can measure in the blood or urine, et cetera, to give us a sense really and provide us a path to approved therapies based on endpoints looking at that. But really glad to and excited to be here, and I'll stop. I look forward to hopefully having an opportunity to interact with some of the patient community, our patient partners tomorrow.
Thank you so much. This is wonderful, Eliza, and we'll continue some conversations tomorrow. And yes, our patients are the most important partner in making this successful foray toward the clinic. So thank you again for your partnership as well. Eric, do you have any other comments that you'd like to make about your perspectives on from all the work that you kind of pulled together for us on protocol biopsies and or biomarkers for these diseases?
So I really think that the approach that I saw today that you have taken, which is an integrative approach where you're not relying on one measurement, is really the key to get this done. But I think that that these diseases are really exemplary for an approach where you really try to use the mutant protein itself as a readout to see what happens when you act on with these drugs. But the thing is then to correlate this outcome afterwards with a clinically relevant outcome, which would probably take more time. But overall, I don't see what could be major obstacles to get this beautiful work that you have started with vesicles, extracellular vesicles, and also within the biopsy, but it should not work. So I'm really optimistic after what I've seen.
Thank you, Eric. That's wonderful, and thank you for your partnership as well and being part of the international team trying to help patients and get successfully to the clinic. Great. Those were my thoughts, and it was great to be able to bring these voices into the conversation. Drew, back to you if you have any remaining questions.
Yeah, I think we may just have one more, and I'm sorry for that duplicate question, Greg. I was just trying to make sure we had them all from the chat, so thanks for answering that live as well. I don't think this is a duplicate question, but correct me if I'm wrong. I think this would be for Dr. Bleyer from Cindy Gleck in the chat. Could SGLT2 be helpful for a MUC1 patient who was transplanted 35 years ago, who is facing a failing transplanted kidney, probably from long-term exposure to cyclosporine?
So there's a lot, so just to talk a little bit philosophically. So I always feel like, nephrologists are, we're so used to dialyzing patients and transplanting patients that we're kind of, and kidney disease progression is slow. That we're kind of like blasé, can I say, about starting new medicines. And if you look at diabetic nephropathy even, there's still a lot of people who are not taking these SGLT2 inhibitors where they've clearly been shown to be beneficial. So I look at these medicines as, for my patients, as what are the potential risks and what are the potential benefits? Because I know there may be a trial in transplant patients, but that may not come out for 5 years. So I'd like to look at the risks versus the benefits, and especially if there's protein in the urine, I think there could be a potential benefit to these therapies. I think you need to talk to your doctor about it. But I would also look, if I were you, I would also look the American Society of Transplant Physicians, ASTP website, and I would try to look into other transplanted groups. You're behaving right now like you would not be a MUC1 patient, you're really a transplant patient. And the kidney that you're trying to protect is not the MUC1 kidney transplant. So I think you're asking, are these indicated in patients with chronic kidney disease who have transplants? And I'm not an expert on that area, but I think there is beginning to be some data in that area.
Great. Thanks so much. Well, we are, these are great questions, and we'll have more opportunities to really have much more of even an open discussion tomorrow, but wanted to just very briefly give a preview. You know, Katie, we're going to be hearing from Katie tomorrow. We did a little switching around on the foundation side, but wanted to give a little bit of a preview of tomorrow. Now, Anna went through our very esteemed lineup for tomorrow, but wanted to just say this. We, as the patient community, could not be more excited with the progress that has been made. And so to be able to dedicate an entire day of this virtual summit to, marching toward a treatment, and having Peter Mundell, keynote tomorrow morning, that is just going to be, for us, I can speak for members of my family who decades and decades, and we've been waiting for the potential of a treatment, and to have have the FDA weighing it. This is all just getting so very real. And so what I'd encourage everyone to do, if you're a patient on today, please encourage your family members and others that you know to join tomorrow. If your nephrologist hasn't already been invited, please invite your nephrologist to join tomorrow. We want this to reach as wide of an audience as possible, so that when the time hopefully does come soon for clinical trials or for patients engaging with the FDA, that we have as wide of a community as possible to engage here. And so, we're just thrilled, and we'll have a very open discussion. And I'd say the same thing to researchers and collaborators. If you're in touch, and some are more distant from patients than others, but if any of you can encourage patients and families to be on tomorrow, and of course we'll record it and blast it out, but there's nothing like having the real-time collaboration. So that's really the only preview for tomorrow. We have an extremely esteemed lineup, and we just want to have as many people as possible join. And with that, I think with that, we'll probably conclude today and give a little bit of time back. We have a long day tomorrow. And just, again, thank you so much to all of you who presented on this scientific program. And we will go, again, same time, same place tomorrow morning, 10 a.m. Eastern in the United States, and hope to see all of you here. So with that, thanks very much. And we'll see you in just a few hours tomorrow. So see you then. Take care.